Welcome back to the XR Theater, everybody. Again, my name is Brennan Spiegel. I'll be moderating today's session here. And let's just jump into it. Our first speaker of this exciting session is Dr. Michael Yashar from here at Cedars-Sinai in Los Angeles. Michael is an assistant professor and an attending physician in our Department of Emergency Medicine at Cedars-Sinai. But he also serves as the director of simulation and education committee co-chair for our simulation center here at Cedars-Sinai. We've had an outstanding and very sophisticated sim center going back many years now here at Cedars, and we rely heavily on simulation to help train our clinicians, not just in VR, but in a variety of different platforms. So today, Dr. Yashar is going to be sharing with us his talk entitled XR and Medical Education, or MedEd Simulation in 2022, Ideal Applications and Avoiding Pitfalls. So thank you so much, Michael, for being with us today. Look forward to hearing your presentation.
Hi, everyone. My name is Michael Yashar. I'm an assistant professor of emergency medicine here at Cedars-Sinai. I'm also the education co-chair for the Women's Guild Simulation Center here. Today, I'm going to be speaking with you about extended reality and medical education simulation in 2022. Of note, we're going to go over some ideal applications while going over avoidance of some pitfalls. Before we get into that, I think it helps to have a little bit of context in the setting of medical education. I think it helps to know where we came from, where we are, and where we're going. So this is what things looked like back in the 1960s. This is what medical education was like. You'd often sit in a classroom, you'd get some lectures, you'd practice some skills on mannequins, and then really you do a lot of your learning practicing on real patients. Now here we are today, and instead we actually spend a fair amount of time in lectures. We practice on mannequins, and you get most of your training practicing on patients, but everyone's dressed completely differently, and the mannequins have better construction, and the pictures are in color, so yeah. But somehow, it's 2022, and we have supercomputers in our pockets with folding screens. We have self-driving cars. We've got vacuums that can avoid dog poop. And we have robots that are doing backflips. But when it comes to training people on how to save lives, we're still, for the most part, doing it the same way. So, it really, raises the question with where we are and where technology is today. Can we use extended reality to answer, some of these problems and make some progress and movement forward? And from my standpoint, I think the answer is yes, absolutely, 100%. Well, maybe, but I think at least it'll help a lot. So now a disclosure, I'm not just an academic with an interest in this subject. I do provide medical oversight for a company called SimX that makes virtual reality medical simulation. That said, this stuff is really near and dear to my heart. And so what I'm going to go over today, it's kind of like notes from the front lines. These are my tales from the trenches in my greater than a decade of experience in the simulation medical education space and VR. So to kind of frame things a little bit, I think it helps to understand why this stuff matters. In America and medicine as a whole, preventable errors are a big deal. The numbers are really high, and we can only expect more challenges with patient volumes and complexity of care going up. This really is a medical crisis, and I think most people only really appreciate the tip of the iceberg. But it's a huge issue throughout the medical field, and we can do something about it. So the airline industry is well versed in this, and they learned a long time ago that the power is in simulation. Practicing your skills frequently in a safe environment does lead to better outcomes. This is something they've been doing since the 1970s in the aviation industry with VR-based simulation, and it's led to a nearly 50% reduction in human error-related airline crashes. But the problem with the technologies that we use for simulation now are that, they're pretty old. This isn't to deride mannequins too much. I have a soft spot for them. I was trained on mannequins. But they really are limited in what they can portray. They can't have rashes, they can't have strokes, they don't walk, they kind of talk. They're expensive to buy, maintain, and operate. And you see here, nobody really is social distancing, which kind of matters these days somewhat as well. And you need in-person training to do this. With VR, it's like there's so many benefits. One is that it improves the realism. You can really have any patient with any tools, and I think the any tools part is really underappreciated. If you have a sim center where you have to buy tons of hardware and store it, that's a lot of cost. And you can do this in any environment. It can be in the hospital, in the ER, in the field, in a helicopter. Flexibility is great. You can set up a case that has been developed in less than 5 minutes. You can run it anywhere, and you can have multiplayer in person or across the world. And like I said, 1/10 of the cost of mannequin simulation, and having these cases automated reduces staff workload. Another thing to keep in mind when you're doing things in the VR space, it's easy to log metrics for feedback. You've removed human error. You can give learners concrete feedback on actions that have been performed, and it's especially great for high-stakes cases that require repeated deliberate practice. On top of that, while it's a new area of interest, the early research shows that it works. And this isn't really what excites me the most per se, and maybe that's my practitioner's hat and not my academic hat here, but there are a lot of things that work well and aren't even used. And I think that it's particularly the case that some things that we've been struggling in the sim lab for years are obvious benefits of VR that stare you in the face. One is take disaster scenarios. These are so important in this day and age and continue to be a huge challenge to pull off in the sim lab or even, it's like in situ. Creating these cases in MR can come with more realism, less support staff complexity, and vastly easier setup and all. Plus, you can run through the same cases as many times as you want with the click of a case reset button. This holds true also for high-stakes codes where you can create these high-fidelity environments without having to buy and store a ton of equipment for every possible scenario. And it's 2022, and when it comes to the physical exam, nuanced things like a neurologic exam continue to be a real struggle with traditional simulation. This stuff is no problem, like with MR. So with that, I think the good news is that there's a ton of stuff out there in the medical education space for extended reality. The question really is where to start. And I think that the best way to do this is to break down the subsegments of virtual reality, augmented reality, and mixed reality, and look at each of the key applications each has in use. So let's start with VR, and I think that's most common right now. This is where you are in a fully closed virtual space, and all you see is virtual content. And so before I kind of dive into that, a brief segue that's worth appreciating. Early on, most of the headsets out there, they were 3 DoF, so 3 degrees of freedom. This meant that you could only really track your head location in 3D space. Now we have 6 DoF headsets, like the Oculus, where you can really kind of like not just move your head, but move your whole body around. And so you're able to add realism rather than just look around in one spot. You can walk up to patients, you can like kneel down to them, you can be anywhere in the room really, which is great. And so, brief overview of what we currently have. We've got things like VR surgical trainers, task trainers where you're practicing surgical procedures, laparoscopic, whatnot. There's anatomy education tools where you can kind of dissect and look through all the layers of the human body. We see a lot of 360 video capture. It's great way of doing kind of front row surgical training, like an advanced version of the operating theater that we've had in the past. And then the thing that it really seems to be used most for are undifferentiated medical presentations, evaluation, treatment, with a spectrum of like options out there, from kind of click-based choose your own adventure models to having, it's like in the VR space, combined didactics and interactive learning. But what really excites me the most are full-on immersive simulation cases. And so I think it kind of works best to kind of show you an example of this. You really can do anything now. You can, grab, oxygen off the wall, place your patient on it. You can, do IV placement. You can go ahead and place a transvenous catheter. You can transvenous pace somebody with equipment similar to what you'd use in real life. You can even do a neuro exam. So it's really come a long way. Now, AR is completely different, and I think that the most popular example out there right now is Google Glass. So augmented reality, as most experts would say, refers to technologies that simply augment the real world. This is oftentimes used in training around manufacturing, warehouse management, and mostly kind of internal wayfinding. And so these are cases where AR really shines, and the key feature really is that it's not particularly interactive. I think the best way to describe it is that it's like a rear view mirror that occupies a small part of your vision quadrant. So, some examples that we see of this oftentimes, used in surgical cases to be able to intraoperatively view prior imaging, so it can guide you along the way. An example here in the upper right, is in industry, trying to figure out, what type of screw you're using just by looking at it, and in kind of textbook education, a way to kind of bring out animations in a 3D space, but not something that you interact with per se. Now, the next big thing is mixed reality, MR, and so we see this with things like the HoloLens, which Microsoft has, and a number of other brands. And this is where virtual content and physical content kind of integrate together in a single scene. In theory, this should be able to provide you with all the benefits of a VR headset plus more, while you can engage with real-world content. And it really addresses the biggest weakness of VR, which is tactile feedback. So some examples here, for example, see visualization of fetal position during delivery. You can visualize cardiac compression and vascular flow, during CPR to tell if you're doing effective CPR. It can overlay on top of actual equipment to show you internal anatomy or ultrasound images. And so, it poses an exciting opportunity to bring new life to existing technologies, whether it's a basic CPR dummy or a top-of-the-line simulation mannequin. So in practice, the potential remains a little bit unrealized, though, because of some hardware limitations. They use refractive technology, and that has hard limits on two big things. One is the field of view and how opaque the visual content can become. So it works for certain use cases, but particularly when it comes to visualizing your field, you don't get a full frame of vision. And this can be difficult with complex medical scenarios that you're trying to navigate and work around. If you were to put your head in one position, you'll see things perfectly, tilt it a little bit, and you'll have an incomplete picture. Likewise, I think a lot of us have this perception of MR from what we see on television or on the computer, and so it's not necessarily in the headset similar to what you'd see on TV. There's a lot of rendering that happens at the end of the day currently, because of the refractive technology, to kind of get a semi-opaque, transparent image, which can be distracting. So with that said, that's kind of where we are. The next thing I wanted to kind of do is go over, hopefully in the next 5 years that are upcoming, what we may see as far as hardware maturity and where it can take us. So what can we look forward to? For one, I think edge computing or cloud computing is really going to be a big thing in the coming years. This is, where the computing is done in the cloud, all the processing. And so I think this is really going to enable wireless headsets to take off so that we can really push the boundaries on realistic simulation in the headset, while making it so that, at the end user level, folks aren't going to need super powerful headsets to have very impressive high fidelity simulations. The other thing is wearable sensors, biometrics, and I think there's actually another talk at VMED about this. But having biometric feedback, things that like allow you to track physiologic stress levels, eye fixation. I think those things are really going to allow learners to kind of be trained sort of like Olympic athletes with sensors, so that you can really kind of give fine-tuned, detailed feedback to learners, and then at the same time be able to kind of adjust cases in real time to their strengths and weaknesses. The other thing that I think is going to take off, we're getting really close to having like hand tracking being accurate in VR. Soon, I think we're going to be able to take controllers out of the equation and have folks be able to actually perform tasks and skills with their own hands as they would in real life. So I think that's going to be impressive. We kind of talked about limited field of view. I think that one thing that we'll get better at and will come to light is being able to give more full view virtual or MR simulation experiences in virtual reality. And it's like they're already looking at technologies that basically allow you to have refraction occur, and so that you can get images directly projected onto the retina, but we're not there yet. Another thing that's really taking off right now, and I think we'll see more and more of, are volumetric image capture, kind of really high volume scans of environments and equipment that you would otherwise want to integrate into your cases. And so there's really basic items and there's really like high-end equipment out there, and I think that we're going to gradually see that so that we can really reproduce reality into the virtual space. Hopefully, I think that we'll see things like smell-o-vision plus more. Smell, is very much linked to memory. If you're a soldier treating a roadside bomb, I think it adds to the experience to be able to have the smell of wounds, sand in your face, wind in your face, and I think that will help advance VR. And I think the last thing to kind of look out for, but I think is a ways away, are haptics. Everybody always kind of asks about this, being able to feel things in the virtual space. And so a lot of those limitations are centered around having to oppose joints. You might think that if you want to kind of like feel something in the virtual space, you just need to oppose the fingers, but that doesn't prevent you from pushing through 3D. So it's really pretty nuanced as far as being able to do something in a virtual space like IV insertion, or even just palpating an abdomen for guarding. You really have to kind of oppose all the joints. And so that's a complex question that hasn't really been solved and needs to be done really well. But hopefully we'll get there in time. So in short, we've come a long way, from the history of mannequins, and XR, is going to make high quality medical education easier and more accessible. It's a paradigm shift for sure, though it's one for the better all around. And honestly, I don't think there's been a better time for each of us to dive in and get our feet wet. Lastly, there are some big challenges ahead, and I'm convinced that in the future, it's people like you that will help get us there. I know that we can, and we'll work that out over time. So in the meanwhile, I thank you for your time, and it's been a true pleasure. I hope you guys enjoy the rest of the conference.
Well, thank you, Michael, for sharing your vision of the future of medical education. And you're absolutely right. This is a paradigm shift, and it's people like you and all of us at a conference like this that can help charter the future of medical education using these technologies that we're learning about today. So thanks again for that wonderful presentation. Next up, I'd like to introduce Lindsay Watson, who is CEO and co-founder of Augment Therapy, which is a telehealth-enabled software company that uses AR, augmented reality experiences, to engage children in physical and occupational therapy. Her talk will be entitled Leveraging AR Across the Pediatric Physical and Occupational Therapy Care Continuum. And hers is one of several talks throughout the VMed 22 symposium that focuses on the evolving role of XR for children. There were some earlier presentations in the XR Theater, and later today, we're also going to have a deep dive, spending 2 hours just talking about the emerging role of MXR with pediatric populations. So without further ado, I'll hand over the stage to Lindsay Watson. Thank you, Lindsay, for being with us today. Look forward to hearing your presentation.
Hello, my name is Lindsay Watson. I'm the co-founder and CEO of Augment Therapy. an interactive software that uses the medium of augmented reality to improve the delivery of pediatric physical and occupational therapy. I'm delighted to be here today to talk about leveraging augmented reality across the pediatric physical and occupational therapy space to improve the care continuum. I'm also a physical therapist, and I've been practicing in the pediatric market for roughly 20 years. And those years taught me that the most important thing in patient care is actually patient engagement, getting them actively involved and participating in the process of their care. Some problems that I noticed in the industry, which really catapulted and catalyzed my initiative to develop this software, was really looking at the market itself. There has been a swell of children identified with the developmental disabilities that we typically treat in physical and occupational therapy. 1 in 6 children right now being identified with developmental disabilities, and a shortfall of therapists across the country to treat them. And this has only been worsened by the COVID-19 pandemic. And all of the statistics really show us is that we're doing a terrible job at engaging our patients, with roughly 70% of patients not completing their episodes of care, and the same amount not adhering to their home exercise program, and 20% of patients dropping out within the first three visits. Couple that with the difficulty accessing care in all environments, and all of this has only been worsened by the pandemic, with 74% of kids reporting a loss of at least one therapy service. And all of these difficulties with engagement really do cost the patient, the provider, and the enterprise. So we developed a solution that was designed to engage patients across the varying settings in one application. And how we did that is by using augmented reality, and truly patient-facing augmented reality, and the ability to create exercise programs within one software application that feels like a game to the patient, but is equally telehealth and remote monitoring enabled, which truly does improve access to care for pediatric patients. And what this results in is, by engaging patients more across the variety of settings, it results in a better satisfaction, higher outcomes, because patients are less reluctant to adhere to their prescribed programs and episodes of care, and resulting in a lower cost of care overall, as patients will maintain this more conservative intervention level and not elevate through the healthcare system to more complicated healthcare interventions. So the value of patient-facing augmented reality that we developed in our application, this is really a unique way of using augmented reality. Traditionally, as you know, patients would wear translucent glasses, and that digital content would be layered over the patient environment. What we do is we turn the camera around on the patient, and the benefit of this is many factors. Number one being that we can provide patient immersion without wearables. So by projecting their image on the TV screen, we provide them with a mirror therapy impact and effect, which, as you know, the pediatric population has particular difficulties with proprioception, where therapists are accustomed to using mirrors to promote that patient engagement, and by seeing that connection between the body and the brain with the reflection in the mirror in front of them. So what this results in is improving this proprioceptive input, and it also helps patients be engaged that otherwise would have difficulty with virtual reality or augmented reality wearables. Within the pediatric population, many of these patients often have sensory processing issues coupled with their diagnoses. And so this enables them to access this type of care without those types of complications. It's further beneficial because we can engage patients without infection control issues, which were a big issue during the COVID-19 pandemic and likely to persist beyond. Also, this enables even younger patients to have access to this type of technology because we don't have the difficulties with different sizing and body types of that matter. And in addition to that, there have been new remote therapeutic monitoring codes approved by Medicare in 2022, and many private payers are adopting those codes as well, which really facilitates this type of technology to be leveraged across all of these settings for an improved return on investment. So this is an example, a rendering video of how it really works. So we take that smart device, the iPhone or iPad, for example, we set it up on a tripod and we connect that device to a television in front of the patient. The patient then sees their reflected image on the screen and they interact with the filtered augmented reality content that we layer over their body. For example, what we do is in this outpatient setting, we can convert the patient image to an avatar, or we change their environment from the outpatient therapy setting to a swamp that patients have to jump through. Here's an example of how we work in the inpatient setting. And we do things like modifying their hospital room to a snow globe where the patient is inside the snow globe and they have to shift their weight onto their affected surgical leg to make it snow inside the snow globe. Here's an example of how the software works in real time. You can see telehealth going there in this first few images. You see how the therapist is actually controlling the device in real time. Here's the software being used at Rainbow Babies and Children's Hospital. You can see how we are actually engaging that patient in the medical setting to move their body. You can see how we do at times convert the patient image to an avatar, but all of this content is designed to engage the patient while we're also capturing objective data on their movement. We capture things like active range of motion, jump height, jump distance, single limb stance time, step counts, all of these metrics, which are very valuable to pediatric therapists like myself across all settings. Now I'm going to show you the solution at work. This is a 18-year-old patient with Down syndrome who received physical and occupational therapy for over 15 years. For 4 years, she had the unmet goal of sustained exercise for 5 minutes. She was actually my patient, and I spent many years with a multitude of techniques trying to engage her. I was never successful. Once we had an early prototype of the software, I put her in front of the interface and she did 25 minutes of sustained exercise in her first augment therapy session. She was very motivated by seeing herself on the screen and how we tied the interactive content to her actual movement, further providing her positive reinforcement for sustained activity while we were simultaneously capturing data on her movement, again, without any wearables on her body at the time. This was a great success story for us. Here's another patient at Rainbow Babies and Children's Hospital. This was a patient 25 years old with spastic quadriplegic cerebral palsy. She had therapy for over 16 years, PT and OT. She was very difficult to engage and exercise, particularly outside of the clinical setting where often she wouldn't adhere to any exercise beyond the therapist being present. This patient, her parents would drive an hour and a half each way to therapy. And she would have this treatment every other week. So they had a very high cancellation and no-show rate. This is one of her first sessions in front of the software. And you can see how the software is even accessible to a patient within their wheelchair. And you can see how she is interacting with the content on the screen there. And she's very engaged with the content overall. This is an example of the variety of use cases where augmented reality truly can benefit patient care. We're already deploying into a number of these settings where patients with chronic pain, radiation oncology, sports medicine and orthopedics, neurology, and cardiac care, all of these patients on some level often receive skilled intervention for therapies. And we are already seeing benefits to all of these patient populations because of the application of augmented reality in this patient-facing format. Here's another use case in action at Rainbow Babies and Children's Hospital, where our software has been installed in the inpatient units there. Why this has been particularly beneficial in this use case is on the pediatric oncology floor where this installation has taken place. It's where these patients often are inpatient for longer periods of time. At many times, they cannot go out into the halls and interact with other patients due to their immunocompromised health at the time. And the software enabled 24/7 access to exercise prescribed by the therapist within the patient rooms. The therapist then, when they come into work the next morning, they can actually see what took place the previous day in the patient room when the therapist wasn't present. And this has been truly transformative at this location for these therapists. We really thank you for this opportunity to talk about this application of augmented reality across the physical and occupational therapy setting and a variety of care continuum spaces. We hope you reach out and ask for more information. We'd be happy to share it with you. Please reach out at Lindsay Watson at augmenttherapy.com or feel free to check out our website, augmenttherapy.com. Thank you.
Well, thanks so much, Lindsay, for your presentation. Really appreciate your perspective. And again, we'll hear more about the use of XR with kids later this afternoon in the deep dive session. Next up is Chris Brickler and Ted Worth from MindVR. MindVR is a pioneering leader in the use of virtual reality for older adults and age-related healthcare. You can learn more about MindVR in our exhibit hall. Check them out. If you have some time, you can talk to these folks and learn more about what they're up to. A very important use case and application of virtual reality. They'll be talking to us about the future of VR for aging health. So Chris and Ted, thanks so much for being with us, and take it away.
Hi, I'm Ted Worth from MindVR. I'm here to talk about the future of VR and aging health. MindVR has been working in the space of virtual reality and older adults for 5 years now, leading the industry in terms of the research and the practical application of VR towards aging and age-related conditions. So the problem that we're addressing here and talking about is the aging population and its growth. So 10,000 baby boomers are turning 65 every day in the US alone for the next 8 or 9 years, to the point where by 2034, older adults 65 and over are actually going to outnumber children under 18 for the first time in US history. That's a massive shift in the shape of the population towards an older population. And along with that comes a rise in senior isolation and loneliness, which leads to anxiety and depression, eventual cognitive decline, and even increased risk of death. So the ability to treat and address these age-related conditions is going to become even more important over the next 10 years as this population shift occurs. Within the world of VR and healthcare, you've probably heard lots of presentations today about the size of this market and the opportunity here. But some predictions have the VR healthcare market reaching $42.8 billion by 2028. Some of the things that are going on that are changing right now are more mass awareness of VR and the metaverse in terms of the general population. Also, the regulatory climate is changing to be more accepting of digital therapeutics in general and VR specifically. And there's a growing body of clinical research around VR therapy. And what we're hoping to show is an increased amount of research around VR and the aging population. So we'll talk for a moment about some of the age-related use cases for virtual reality. So first off is isolation and loneliness and how that can lead to anxiety and depression. As we all know, with the COVID pandemic, most of the population has become aware of just how difficult it is to be isolated and lonely. Well, the senior population deals with that before COVID, they dealt with it through COVID, and they'll still be dealing with it after COVID. Whether you're living in a senior living home or aging in place on your own in your own home. Mild cognitive impairment and Alzheimer's and related dementias are a major concern for the aging population, as is Parkinson's disease. VR can be used to treat all of those. Obviously, VR can be used for pain management. We're going to see an increase in VR for physical therapy and occupational therapy for seniors. In particular, we believe helping to teach or reteach the activities of daily living that seniors need to either maintain or relearn after having either dementia or cognitive decline or strokes or other things that might affect their ability to handle these ADLs. There's an entire use case for VR within veteran care and PTSD. And there's also a use case for VR in hospice and end of life for older adults. So what needs to happen for this to really reach its potential are four things. There has to be more VR that's actually designed for the senior audience. That's both the content and the devices, the ergonomics themselves. There has to be a certain scale of reaching a significant number of seniors, which is not necessarily that easy to do. We have to continue with the research to show the efficacy of VR for these age-related conditions, and we have to work on the affordability and the payer models that will allow more seniors to actively participate in using VR. So first, we'll talk about VR designed for seniors. And we at MindVR look at this in three buckets: the content, the connectivity, and the interactivity. And what I mean by the content here is VR content that's actually produced specifically for the older adult audience, meaning we're not just repurposing gaming VR that was built for a youth audience. So this means recording things with the right pacing, with the right voiceover, with the right background music, with the right camera angles and motion that are actually geared towards an older audience. It means picking the right subject matter and not just trying to repurpose first-person shooters and zombie apocalypses and alien animations and all the other sorts of things that maybe aren't that in tune with what the seniors are looking for in their VR experiences. We talk about the four walls syndrome, which is creating content that really helps seniors feel like they're escaping from the four walls that they're otherwise confined to. If you're relatively immobile, if you're essentially within the same room or home, again, whether it's a senior home or your own, you're very conscious of the four walls that are around you. And so content that really makes you feel like you're transcending those walls and getting out of that physical space that you're in is very important for treating senior isolation and loneliness. And then there's VR that's designed and targeted at these specific age-related conditions. So, for example, in the world of Alzheimer's and memory care, creating VR that is used as a reminiscence therapy to help trigger memories, VR that can be used as music therapy, that is using music specifically from the era of these older adults. We also talk about VR designed for seniors in terms of the headsets and the ergonomics. So headsets that are lighter, easier to put on. We found that one of the only times that older adults in a senior home didn't want to use VR was after their hair day. They had been to the salon and they didn't want to put on a headset that would affect their hair. So for example, a VR immersive glasses like the new Vive Flow that just slip on and don't actually wrap around the head. Things like that are making VR that much more appropriate for older adults. Next is the interactivity of the VR. And this refers to the actual interaction with the content that can be used to make therapeutics and rehab treatment more fun and more enjoyable. And there's a lot of research that shows that if you can make therapy more enjoyable and engaging, that people are more inclined to follow through with their therapy and their treatments that they've been prescribed. And it can have very, very positive benefits. There's also the interactivity that's evolving from the actual headsets and the controllers. So controllers that are easier for older adults to use. And what we think is very exciting is coming soon, which is the real hand tracking using the cameras mounted on the front of headsets that would allow seniors to participate and interact in VR experiences without having to hold cumbersome controllers that a youthful gaming audience might be very comfortable with. Also within the world of interaction is the interaction with the caregivers and the staff, creating experiences that bring the interaction together with the person in the room, the caregiver sitting there with the resident or patient, and able to talk about and participate in the VR experience together. We found that there's a benefit both to the resident and the staff in having VR being this sort of interactive experience that increases and improves their relationship. And that has positive effects on both and their quality of life. The next aspect is the connectivity. So as 5G rolls out, as all sorts of other better bandwidth, better Bluetooth, all of these things that make the real-time communication through VR faster and easier is going to have a lot of ramifications on the older adult audience. So if you think of grandma or grandpa living in a senior community, say in Austin, Texas, but their grandchildren are living in Chicago and New York and Oklahoma, and they can all participate in real time in that live VR experience. That sort of connectivity has tremendous benefits, especially as we look at intergenerational interaction and connectivity. I'm going to show a short video here of that type of.
Welcome to the world of Mind VR, where virtual reality meets healthcare for our aging population. Seniors are facing isolation and loneliness more than ever. That's why we are introducing Mind Connect, which virtually connects seniors in the metaverse in real time with remote family members from anywhere.
Hey, Grandpa.
Hey there, kiddo. I've been looking forward to spending some quality time together.
Me too. So where would you like to go today?
How about a trip to the International Space Station?
Ooh, good idea. Let's go.
Wow, the flight into orbit didn't take long, did it?
No kidding.
Look at all that water. You think there's any fish down there?
I think I see one or two.
The Future of Comfortability by HTC Vive. The future of human connection with Mind VR. Mind Connect, bringing smiles on faces.
So again, this is just an example of the kind of intergenerational connectivity that is coming down the road, both from Mind VR and lots of other entities in the world of VR healthcare. The next thing we want to talk about is scale and reaching the senior audience. Really, to make this a reality, we have to be able to reach large numbers of seniors and get them engaged so they can interact with each other. Some of the ways to do that are through partnerships. For example, again, at MindVR, we have relationships with AT&T, Select Rehab, and Omega, which are some major players within the world of already providing services to seniors and senior care homes. And it's through channel relationships and partnerships like this that we believe VR is going to reach large masses of seniors in order to really to provide some efficacy for them. Another thing that needs to happen is more research into VR and the aging population. So we're currently working with Stanford University, Jeremy Bailenson there at the Virtual Human Interaction Lab, on a study to examine how VR might affect technology adoption among seniors, with the idea that VR is a somewhat easy technology to adopt. And if we can get seniors to adopt it, it might actually help them adopt additional technologies that would be beneficial to them as well. But we're open to other partnerships for anybody out there who's interested in conducting research to help advance the cause and to move the industry as a whole along in terms of VR and aging health. The last really important piece here is affordability and payer models. And there's been some very exciting news recently, which is the Access to Prescription Digital Therapeutics Act, just introduced on March 10th of 2020. This is a bipartisan legislation that was introduced to try to move digital therapeutics along faster and get Congress and get the whole country behind this concept, where digital therapeutics will get reimbursed and paid for by insurance, by Medicaid, by Medicare. It's very exciting for everybody in the industry to see how this could happen. It was also very exciting to see some of them call out specifically the use of VR and digital therapeutics for older adults. For example, our bill ensures these prescription digital therapeutics are covered by Medicare, so more patients, including seniors, have access to the cutting edge care they deserve. So we're all hopeful that there'll be full support of this bill and others that will continue to advance digital therapeutics as a category. I'm sure you'll be hearing a lot more from others in the virtual medicine conference here talking about these models. It's really very exciting for the whole industry. So thank you. I appreciate your time. I hope you enjoyed this, and I look forward to connecting with you. Please feel free to reach out. I'm again, Ted Worth, ted@mindvr.com. Happy to talk about anything related to VR and the aging population. Thank you.
Well, thanks so much, Chris and Ted, for sharing your work at MindVR. Next up, to round out this session of the XR Theater, I am really pleased to present Korak Sarkar, who is as many things. He's an assistant chief of medical informatics at Ochsner Health in New Orleans, and the director of the Ochsner Medical 3D Laboratory, which applies advanced manufacturing and mixed reality to healthcare delivery. He is also a graduate student separately in our health delivery science program here at Cedars-Sinai. So I've really enjoyed getting to know him both on the professional side and on the graduate school side. And so I'm so pleased that he's with us today to present his work at Ochsner. Today, he'll be giving a talk entitled Lessons at the Intersection of 3D Printing, Mixed Reality, and Healthcare. So without further ado, Korak, you're up. Thanks for being with us.
Thank you for that warm welcome. Today, I'd like to talk about how Ochsner Health is using advanced manufacturing, mixed reality, and advanced visualization here in Louisiana and throughout the Gulf Coast. And also to discuss how these tools in conjunction with design thinking supported our response to COVID in the region, and then briefly explore the future of these innovations in healthcare. But first, I'd like to go over some definitions. So when we talk about manufacturing, there's two broad areas of manufacturing. One is subtractive, which is actually by and large the most common. And whenever we're talking about manufacturing, almost invariably, we're talking about subtractive manufacturing. And there's a variety of approaches, But the prototypical example is sculpture. You have a piece of stone, a skilled artisan chipping away, and out emerges a sculpture. And this one is one of my favorites by Elian Zimmerman at the Besthoff Sculpture Garden right here at the New Orleans Museum of Art. And the 3D printing, or additive manufacturing, as it's also called, correlate is to take a variety of methods and materials and basically put one layer on top of another to create a three-dimensional object. Similarly, mixed reality has two main areas. One is virtual, where you use a head-mounted display or an HMD and a headset to completely immerse yourself in a virtual environment, or augmented reality, where you can use an HMD like a HoloLens, or just use your phone without a headset to project a digital object into the real world. And this is the impetus for me to understand and start using 3D printing and immersive technologies. And it's basically very difficult for our visual systems to reconstruct 3D data from 2D planes. And this is a CT scan of someone's head, and it's cut in axial planes like this. And left and right is switched out of convention, and I joke out of confusion. And so the right side of these images is actually the left side of the brain, and you see some accumulation of contrast, and that is an arteriovenous malformation. So this individual had a seizure, presented, and actually had something called aphasia, difficulty with language, because where that is in the left temporal cortex is what's being lit up right now as you're listening and I'm producing language, because that's where language is localized. And so this was even more difficult to communicate to the individual. And uh, I thought, why don't we just, make this in a more organic and consumable 3D format? And that was around the time when MakerBot was introducing 3D printing sort of to the masses. 3D printing has been around probably as long as I've been alive. But around 2013, a tinkerer, an early adopter for a couple $1,000s could get one in their garage for the first time. And I'd never used one, let alone actually seen one. But I thought, why not give it a go? How hard could it be? And almost 10 years later, there's a lot of negative learnings. But um, from that process has emerged our workflow. And this is where we take traditional medical imaging, CTs, MRIs, and transform them in a process called segmentation to output three-dimensional files, things that can be 3D printed, displayed in VR on holographic displays like the Looking Glass, or using augmented reality like the HoloLens, or simply on someone's computer or a tablet, and just manipulating things in 3D, even if it's on a 2D plane. And this is an example of a case that we were able to support. And on the left side, it doesn't take a spine specialist to appreciate that there's something not right. And on second pass, you may actually notice some lesions on this individual's face. And embryologically, our nervous tissue comes from the same place as our skin. And so those lesions you see on our skin were in her nervous system, her spine, and she actually had previous surgeries. And in one of those had lost a blood vessel, an important one called the vertebral artery. There's two of them. She lost one. And so, even though she was having a extreme deformity, pain, muscle weakness, it was affecting her function. Previous proceduralists had said, no, it's too risky. Cervical or neck surgery by nature of the hostility of the anatomy is already complex, and then you've lost a vertebral artery. The morbidity and mortality on this is very high. But with the Dr. James Kalivas, our point on complex spine, and his team, and with these tools, he was able to come up with a procedural approach that was safe and successful, as you can see photographically, and I can confirm clinically that they are doing well. And this, sort of started answering the question that has kept me up since the beginning of this journey: is this a toy or a tool? And like any good question, the answer is it depends. And so we sent out 20 surveys to 3 different clinicians in spine. That's one of our earliest adopters, one of our first mature applications. And 75% of the cases were rated as extremely complex, as you would imagine, and 20% was rated as moderately complex. And Over a third of the time, these staff level physicians, it's not pre-med medical students, residents or fellows, these are autonomously practicing surgeons. Over a third of the time, they appreciated something in the three-dimensional object that they did not in the standard 2D uh, presentations. And this changed their procedural approach a quarter of the time, and that led to self-reported a median of 30 to 60 minutes saved in the OR, which better for the patient, obviously, resource better, 50 to 100 minutes, $50 to $100 a minute in the OR, depending on where you are, what you're doing, and more access so that we can deliver more care to our community. And these are our volumes, going back to 2018, where we sort of had our debut, made a footprint, a small one. 2019 was our benchmark year. And then in 2020, we obviously were affected by the pandemic. And even though a lot of our cases are for complex cases, complexity doesn't necessarily mean urgent. So a lot of these were elective and they were shut down. But even then, we were able to maintain some volume. And last year, with the pandemic lingering, we were able to surpass our 2019 benchmark. And this year, we're on track to double our 2021 numbers. This figure shows a ratio where on the numerator we have total number of models in that year, and in the denominator we have number of clinicians we engage. So number of models per clinician, and you can see in the early years it's sort of one or two. People are trying to understand this technology. How does it help? How can it help? Is it even helpful? And then in the last couple of years, particularly last year, you see that number increase to 7, meaning for each clinician we engage, and on average we're providing 7 models. And the thick data confirms that, yeah, these advanced visualization tools in specific situations are being integrated into clinical workflows. And this shows sort of some of our breadth. So I'm a cognitive neuroscientist. So I live in neuroscience is my home field. You can see the consistency even in 2020 of that number in purple. And then in 2021, there's also, these are our 4 top utilizers: cardiothoracic surgery, orthopedic surgery, transplant, and then neurosurgery, neurosciences. You see transplant in yellow kind of break out of the pack, and it's definitely associated with a biomedical engineer being embedded. And I would posit that that is also causative. Having technically sound engineering and segmentation embedded in a clinical environment so that that work can be clinically informed by the clinician, adds a really unique value. And so here's a picture of another one of our spine models, retrospectively, but post-procedure. This is an actual 3D printed model. And so kind of demonstrating what we're doing, using 3D printing for anatomical modeling and VR and AR for education, procedural planning. We did some work in AR where for procedural training with medical students on something called lumbar puncture in a simulation center, not on patients, but really begin to use these tools. And then, it's hard not to envision a future state where we could use these advanced visualization tools to really inform design of personalized instrumentation that we could feed into advanced manufacturing infrastructure and produce it locally or semi-colocally, and then using AR to deliver this care in a more effective and efficient procedural path. But how do you get there, and how do you cross that chasm? And I would have, if you asked me a couple of years ago, I would have, said maybe graduate medical education. They're the next generation. Maybe they're already using, these tools or playing VR video games, and it seems sort of inevitable. But I wouldn't have hung my hat on that theory. And then something happened that, amongst other things, started to answer that question, and that's COVID. Started in December in 2019, and March of 2020, New Orleans had our first registered case, and our region was hit early and hard, and fortunately repeatedly, which had a multitude of effects. And one of the first and initial ones was a magnitude, if not orders of magnitude, increase in the demand for personal protective equipment, and unfortunately, it inversely decreasing supply due to a 20th century just-in-time, unit price-driven, often overseas-based, and unfortunately rigid supply chain that ground to a halt. And that's where biodesign thinking came in. Needs started to emerge, and one of the first, talking to a buddy of mine that's a critical care doc, was face shields, and there was already open source designs out. We prototyped and really worked with the frontline providers, the nurses, the RTs, the critical care docs, to make sure that the design made sense. But then we got to the point like, it's one thing to 3D print 10, but we're going to need 100,000 of these. And so how do you create, sterilize, store, and track the 100 or so thousand that we felt our 40 hospital system in the midst of a pandemic, that's what we forecasted needed. And then also, in the spirit of trying to do things, not forget about that fundamental precept of not doing any harm to, our colleagues and to our patients. So kind of organically, an ad hoc task force emerged of infectious disease and control, supply chain. Is this a need? Where is the need? And working with our environmental services, really, some of the biggest unsung heroes during all of this, the ones that came and cleaned and helped us distribute some of these tools as well. And so we were able to create this, and then as we all kind of learned, there was a lot of different potential needs, and we leveled up, and started recognizing other needs. And before short order, like the word spread, and other needs started coming to us. And a lot of areas had difficulty procuring hand sanitizer. So the distilleries and the breweries locally, and fortunately, New Orleans has some great ones if you have the opportunity to make it down here, created over 25,000 liters of hand sanitizer. But unfortunately, our legacy dispensers, they didn't jam well. So from needs recognition, recognizing the need, to actually deploying 1,000 of these dispensers was about 6 months. And of course, we're not making electric vehicles or microprocessors, but these had electrical components, mechanical components. There's tolerances and safety. Ethanol is flammable. How do we do this right and safe? And it was amazing that within 6 months there was 1,000 of these out and about in our hospital system and in our community. And this, I would say, is our most successful product, and it was the furthest from our core competency. Textiles and fashion. We had Serendipity, one of our lab members, had a boutique, so he had some knowledge, but there was a lot to learn, and we did it quickly. And one of the first things was there was no way we were going to be able to compete with the unit prices that we were used to if we had disposable medical barrier gowns. But if we could approach sustainability if we created something that was potentially reusable. But this was a logistical and a cultural paradigm shift. And but we worked with the task force and really with the end users, and engendered the trust through the biodesign process, and we're able to deploy over 100,000 of these. And this has culminated in the opening of a 400,000 square foot PPE manufacturing site here in Louisiana through an organizational Ochsner, a regional in Southwest Louisiana, and a state collaboration. And not only adds resiliency to our local healthcare supply, but will end up infusing $150 million worth of cash, and over 1,000 jobs will be created. And it was just time. Within months of this announcement, our region was devastated and is still recovering from Hurricane Ida. And that also affected our supply chain. So we're still it's still a long road to the aspiration, but there are a lot less people asking why hospital needs BMEs or 3D printers embedded in their healthcare operations. A lot more people asking how can they integrate those kinds of tools into their healthcare operations and their clinical practices to help their patients. And I would say we're subtly but significantly closer to a more sustainable, autonomous, personalized healthcare system, a care delivery approach that is by us and for us. So I want to thank all the this is just a subset of the amazing people and groups that made this happen. I'm really grateful to be a part of an organization that's so forward-thinking and a community that's so resilient and wonderful. So look forward to engaging with you.
Well, thank you, Korak, for sharing your work with us today here at VMed 22. Really appreciate the work that you're doing, which is innovative and meaningful. Now, we're going to end now this session of the XR Theater. This is an opportunity for you to go take a bio break, whatever you need to do. Please, once again, consider checking out the virtual exhibit hall. We have 20 outstanding exhibitors with a wide range of products and services, hardware, software, programs that cover the whole breadth and depth of medical extended reality applications, from therapeutic applications to simulation to education. Check it all out. You can go look at the materials. You can also try and schedule a meeting to speak with the individual members of the companies, and I'm sure they'll be happy to speak with you and teach you more about what they've got. So that's occurring now at 11 o'clock. We are going to come back and we're going to then head into the deep dives. So these are three concurrent sessions that gives us an opportunity to get really deeply into the material. Pick one of the three sessions. Again, everything's being recorded, so you'll be able to go back and watch whatever you missed later. But if you really want to get the most out of the conference, get on the live chat, talk to one another, exchange notes. Deep dive A, more than just games, use of VR in pediatric populations. That'll be moderated by Kate Donovan. Deep dive B is titled The Fourth Hurdle, Gaining Market Access and Reimbursement for Prescription Immersive Therapeutics. And that is going to be overseen by Andy Molnar. Deep dive C is called Brain Power, VR as a tool for neurorehabilitation and neuroscience, moderated by Itai Danovich. We have incredible panelists in all three sessions. It's hard to pick the best out of those three, but I'm sure you'll find a way. So in any event, go ahead and take a break, and we will see you back at 11 a.m. Pacific time. Take care, and I hope you're enjoying the conference.
you.